Hello, my name is Wendy Woodward, and I am honored and delighted to tell you about the progress in inflammatory breast cancer research over the last 10 years. 10 years ago, as you know, the state of Texas worked together with patients and physicians to dedicate the first inflammatory breast cancer program, including both the clinic and the research program, and a lot has changed in 10 years. We now see over 100 patients a year, a really significant volume that's contributed dramatically to our understanding of inflammatory breast cancer. It contributes to how we take care of these patients in a day-to-day way. It contributes to the new agents and new trials that are available to those patients. We started the first inflammatory breast cancer multi-team clinic. It's now the case that a patient can come in to a single appointment, see an expert IBC radiation oncologist, medical oncologist, and surgical oncologist in the same visit, and right there get a whole packaged understanding of what the right treatment plan is for their individual disease. We have 13 open clinical trials for inflammatory breast cancer, as opposed to virtually none that were available 10 years ago. And we've now had more than 450 patients participate on our registry, agreeing to give us serum and tissue samples and history and exposures so that we can really better understand how to beat this disease. Importantly, we've been able to leverage the infrastructure that we've gotten from the state to bring in extramural research funds, over $11 million in extramural research funding, and over $500,000 in philanthropy. And it really has taught me the importance of having stable infrastructure funding to allow you to really creatively develop high-impact projects that we can put forward for other funding to do those pieces and hang them on the infrastructure that's provided by the state funds. So what do we spend the funding on? We spend about $450,000 on expert employees in the clinic who are there for our IBC patients. We spend about $500,000 a year on clinical research, supporting the infrastructure for the registry and the trials and the multi-team clinic, and we spend about $650,000 a year on preclinical research so that we can develop the targets and the understanding of the disease that will help us design the clinical trials that make a difference. 10 years ago, if you had asked me, what are the real clinical pearls related to inflammatory breast cancer? What do we do differently in terms of taking care of these patients? That list would have been relatively short. For sure, we knew then and know now that getting chemotherapy first to ensure that you've had response and can have a good margin negative surgery is tried and true, absolutely the right thing to do. We used to offer all patients accelerated radiation therapy. In the subsequent 10 years, we have a list that's much longer of our understanding of what's really different and novel about inflammatory breast cancer and how to take care of it, even just understanding the basic tools in the clinic. One of the things that we appreciate is that a swollen breast overnight with the skin change that looks like an orange is still inflammatory breast cancer, even if it's not red. Not everyone's skin tone affords a brisk erythema as described in the staging system, and this is a real critical issue that we need to address in the staging system so that everyone understands that. We've seen that contralateral lymph nodes, nodes on the opposite side, actually happen really often, and this is still a curable breast cancer as long as you remove those nodes and treat the regional lymphatics appropriately. We wondered if it was okay to do a sentinel lymph node biopsy in a patient who has node-negative disease. We've done a study. It's not okay. It doesn't map appropriately. We really need to do an axillary lymph node dissection no matter what. We've identified that the ER-positive disease that's so favorable in non-IBC does not have a favorable outcome or the same favorable outcome in IBC, and we really need targeted therapies for this group as well and to understand why they don't respond the same way. We understand now that inflammatory breast cancer is enriched in the triple-negative and HER2-positive breast cancers, and that the HER2-targeted agents work really well in inflammatory breast cancer, and it's critical that these patients get these standard of care therapies. Importantly, looking at the National Cancer Database, we've seen that trimodality treatment saves lives, and unfortunately, almost 25% of patients around the country aren't even getting the 3 tried and true therapies we know they need: surgery, chemotherapy, and radiation, and that would be a critical place to have impact around the country. We know now, too, that while more radiation is probably needed for some inflammatory breast cancer patients, it's not necessarily needed for absolutely everyone, and we are much better able to pick and choose who needs that aggressive radiation and who should take on the toxicity from that, and who may be able to step that back and still expect a really wonderful local control. We also now realize that reconstruction might be safer than we thought. We used to advise no reconstruction in inflammatory breast cancer. In a very cautious multidisciplinary way, we've stepped forward exploring this, and we've reported our results that this may be safe in carefully selected patients. So the bottom line in the clinic is that volume has made a huge difference for us. Having so many more patients so that we could really get our arms around trends and changes and understand what needs to be done is critical, and it is so valuable and important to have had this dedicated clinic for the clinical patients. I'm going to teach you something for a minute about how survival curves work so I can show you how the survival has improved since the clinic opened. So when you look at these curves, when you start here at time 0, time's marching on here on the x-axis, what happens at the very beginning is at the time of diagnosis, of course, everyone is alive and well. And as time marches on, each time somebody succumbs to their disease, the curve drops. And each time someone has reached their last follow-up but is fine, there's a tick mark. So every patient is represented on this curve as either a tick mark at the last time they were reviewed and are fine, or a drop in the curve when someone has succumbed to disease. So what you can appreciate is that the number of patients who are still alive and well after the opening of the Morgan Welch Clinic, as opposed to the number who've succumbed to their disease in the setting before the clinic opened, is really substantially different. And while there are many, many factors that contribute to this, the importance of those HER2-targeted therapies, the opportunity to enroll on trials after recurrence has happened, it really is clear that the multidisciplinary clinic is able to provide a better outcome than we were here even at MD Anderson prior to that. What else is different? 10 years ago, it was not typically the case that we talked about surgery and radiation to absolutely every metastatic inflammatory breast cancer patient. But now that you're an expert in these survival curves, I can show you the data from patients who have metastatic breast cancer who either had surgery and radiation, these are patients represented on the yellow curve, who had surgery alone, or who had radiation and systemic chemotherapy alone. And what you can appreciate is an almost unprecedented 50% overall survival for the patients who had surgery and radiation, even though they had metastatic disease. And we're working hard to understand who are the patients who really benefit from this the most, but we are developing a trial concept for the NRG to understand what is the burden of disease in the breast if it recurs if you don't have surgery, and what is the chance that that's really impacting outcome. So this has been a really dramatic finding and influences the way that we think about and talk about local therapies in the metastatic setting. So what is IBC? One of the biggest questions facing us when we first started in the clinic was to define inflammatory breast cancer. Is it radically different from non-inflammatory breast cancer? And one of the things that we did was we contributed patient data and patient tumor data from MD Anderson Cancer Center with 2 other international sites in Marseille and Antwerp to form a large enough World Consortium data set of array and gene information from the actual tumors that we could really begin to make robust comparisons between IBC and non-IBC. And the collaborators in the World Consortium have published many, many papers from this, demonstrating some really critical differences. And one of them that I'll highlight today is that only 3% of the tumor gene expression is different. So in the actual tumor cells, there are some differences, but that may not be the #1 driver. And in fact, most of the signature that they identified from the inflammatory breast cancer in the IBC-like signature is actually from non-tumor cells. And so we really began to understand the importance of the cells that are around the tumor cells, the cells in the breast, for how they influence inflammatory breast cancer. And that's a marked difference to what we were thinking about 10 years ago. So 10 years ago, we were asking the question, why is it that the inflammatory change is really confined to the breast mound? Why doesn't it spread beyond that? There's no clear reason for this. There's no boundary around the breast. There's no fascia there to stop the change right there. And it really made us start to think that breast cells and the cells that have migrated into the breast, maybe even before the disease happened, may actually be complicit in this disease. So today we've seen and published that in fact you can, in a mouse, put tumor cells in the mouse mammary gland, which is down here in the groin in this case, and actually have a tumor develop that looks more like an inflammatory breast cancer than if you don't add additional normal cells from the breast, in this case mesenchymal stem cells. And in fact, when you block a different type of cell, the macrophages, that work together with these cells, you can actually eliminate the skin invasion in this mouse. So giving an antibody that takes out the macrophages, even when you give these mesenchymal stem cells, makes it so that you don't see this inflammatory breast cancer phenotype in the mouse. And so we think in a real change from what we were thinking 10 years ago, that inflammatory breast cancer symptoms are a function not just of an inflammatory breast cancer tumor, but also other normal cells that are helping and that could be potentially targeted for novel clinical trials. We've made progress in terms of tools. A few years ago, there were only a few cell lines, 2 PDX models, not all widely available. Today, we've made an additional cell line that grows tumors in mice, the MD Anderson IBC3 cell line. We have 4 new MD Anderson patient-derived xenograft models that we can grow in mice and use to study new agents. The Fox Chase Cancer Center, under the direction of Dr. Krista Finelli, has created 2 new PDX models, and there are numerous national MTAs to share these resources. So in contrast to where we were 10 years ago, there really now is a sharing and dissemination of an increased number of models so that we can really try to do more faster. How about targets and trials? 10 years ago, there weren't clear inflammatory breast cancer targets that were being incorporated into clinical trials. Today, we know that EGFR is an important target, and while we could not for the life of ourselves get funding to examine this because EGFR just didn't look exciting in non-inflammatory breast cancer, we've run our own in-house phase 2 study targeting EGFR, and we find a 44% pathologic complete response rate for the triple-negative breast cancer patients who got this agent in combination with carboplatin, and we're taking that study forward to look in a broader group of patients. Is this really an important new agent to help improve the outcomes for triple-negative IBC? At the same time, colleagues at the Dana-Farber, as well as work that we've done here, has looked at the importance of IL-6 in driving both the stroma and the tumor for inflammatory breast cancer, and the TBCRC, one of the national groups, is about to open a trial of a drug that's targeting that specifically in inflammatory breast cancer patients. We've done a lot of work looking at the role of statins in inflammatory breast cancer, where they actually make the outcome better. We know that statins can actually target both the tumor and the stroma, and we're about to open a trial here for inflammatory breast cancer looking at that as well. It's not the only work going on, but for sure today we can point specifically to new trials, new targets, new agents that are important for inflammatory breast cancer and offer these patients new IBC-specific opportunities. We've made a lot of progress in education. We've published many chapters, we've published many papers, and I just highlight a few. The Inflammatory Breast Cancer Update. We have chapters in the MD Anderson treatment books as well. I had the opportunity to author a personal view on how the normal breast works together with the tumor to create inflammatory breast cancer. There have really been a lot of opportunities to contribute to the literature and to our general understanding in the last 10 years. We've heard from some amazing advocates, and for sure the advocates who helped to start this in the beginning have been such allies in this development. But I'll highlight just for a moment even a new inflammatory breast cancer charity that's come along in the last 10 years, very much as a function of the dedicated program, the Inflammatory Breast Cancer Network, and highlight that there's now an IBC app that's been created by the network. You can go online and download it and look up facts, trials, patient experience stories. So important. They've been fantastic in raising funds for the trials that are ongoing, and this has been a really critical aspect of development in inflammatory breast cancer. So I want to say thank you. We wouldn't be here without all of the advocates and supporters and patients and physicians and collaborators around the country and around the world, the important physicians who helped to start this. All of it has been so critical, and progress has been made and will continue to be made. If you want to continue to be a part of our journey, please tell someone about inflammatory breast cancer. Be a part of our fundraising army. Now through November of 2016, we're raising money for the MD Anderson Boot Walk under the Team IBC Wranglers. You can reach out to us at any time if you'd like to help us in any way or help contribute to our cause. We're so appreciative, we're so excited about what's going on, and we're so hopeful for the future. Thank you.